For tonight's COVID conversation, we're joined by Dr. Bambra, a pulmonologist with SIH. Dr. Bambra, thank you so much for being with us this evening. Yeah, we appreciate it. Yeah. I guess, kind of an easy question to get me started here. What is a pulmonologist?
Well, a very easy answer is that pulmonologist is a lung doctor. We take care of people with lung problems. Most of the pulmonary physicians are also critical care doctors. That's the pulmonary and critical care as a combined specialty. Okay. Yeah. With SIH, my role is to take care of people who are in ICU, predominantly with lung infections. And with COVID, I have been involved in last 18 months taking most of the COVID patients who are very, very sick and on mechanical ventilator or requiring very high oxygen requirements.
Wow.
Yeah.
Wow. I can't imagine, what you're seeing and what you're going through. Now, you are one of the leads on the critical care team. What does that team look like? What do you do?
So it is a multidisciplinary team. It consists of the pulmonary and critical care lead physician, along with a respiratory therapist and critical care nurses. Typically, the COVID patients require 1:1 ratio. That means that for one single patient, there has to be one specialty nurse for that.
Wow.
Okay, and often we actually need more than that to take care of patients when we are managing them with the specific positioning in the bed and all the drips they are on and mechanical ventilation.
Wow, a lot that goes into it.
It is a team effort.
And, may I ask, as someone who, studies the lungs, specializes in the respiratory system, when COVID-19 was first kind of coming to light, you were first hearing and seeing the symptoms, what went through your mind?
So it's quite a story. I visited India in November 2019. The first time we heard about the COVID, cases, that was in December 2019. As a lung doctor, anytime when we hear about these cases, it is a trigger in our mind. We have had SARS before. We had Middle Eastern respiratory virus called MERS before. And so at the back of the mind was that, okay, is it some of those contained epidemics, or is going to be much more of a problem? And by January, we were hearing more and more of the cases.
Yeah.
And by early February, or late February, early March, we were saying, okay, no, this is a serious problem. I was actually in New York in first week of March, okay, when the whole thing started to blow off. Yeah. And I still remember the date. It was March 12th, 13th, when I came back. And SIH set up what we call an incident command, which is a very focused group of senior physicians, leadership, to prepare the system for incoming wave of the COVID patients. And we got a head start by about 7 days. And I think about 7 days we were able to set up our systems so that when the patients actually start pouring in, we were in a better position to take care of them.
That's a quick turnaround.
Yes.
7 days.
Yeah.
Wow. Wow. Thank you for that. And we hear about, how COVID kind of attacks our lungs. What does it do to a person's lungs? So
the point I want to get across today is that COVID is more than a pneumonia. Okay, COVID is much more than just an infection of the lung. It is also a immune system dysregulation. So what happens is that when the virus goes into the body, yes, it infects the lungs. Okay, it causes the pneumonia. However, the body goes into overdrive. Okay, it produces a lot of chemicals or a cascade of immune, substances, which originally are actually there to protect us, but once they go into an overdrive, causes a lot of harm into the body. So when it comes to the lungs, I describe COVID to my patients and their relatives as a hurricane. It comes and it literally rips the lining of the lung apart. Okay, and when that lining is destroyed, the next step is exactly I would like you to visualize a bruise on your arm. If there is a big bruise on your arm, what happens? The fluid seeps out, right?
Yeah.
So when that lining of the lung is kind of damaged, this starts to collect a thick fluid over there, and it becomes difficult for oxygen to exchange into the body. So the air sacs are filled with that fluid. The person cannot breathe, and literally they are kind of smothering without oxygen. Okay. Wow. Most of the patients, it's self-limited. They get pneumonia, we give them care, and they get better, they go home. But in a fraction of the patients which we see, they become very, very sick, requiring, a significant higher amount of oxygen, mechanical ventilation and other modalities just to survive.
And what are the long-term effects of that? Or, we even hear about COVID long haulers. I can imagine that would, kind of be, a lot to work through after all that damage is done to your lungs.
Yes. So I have a lot of patients who have survived COVID, and when they come to me, they still complain of significant problems. And I divide them into two groups, problems related to lungs. That is, they still get a lot of shortness of breath, wheezing, phlegm production. They feel that they are still not back at their baseline. They get out of breath very easily. We attribute that to the direct damage to the lungs. The other phenomena are that they have significant memory problems, muscle aches, what they describe as brain fog.
Yeah.
And we do not exactly know the reason why it happens, but again, it goes back to my description of immune dysregulation, that the COVID and the whole cascade of the chemicals which are produced, it causes changes in the body, which causes all these side effects. Okay. Yeah, and it does take a long time to clear up.
And as a pulmonologist, as a doctor on the critical care team, are you seeing significant differences between this wave of COVID patients as compared to maybe, at the start of the pandemic?
Yes, there are significant differences. The first wave was what we describe as an alpha variant, and the second one is the delta variant. The first wave I'll describe is COVID of, people who were more confined into nursing homes, 70s, 80s, elderly people. This wave is the wave of younger people. They are moving around. As they move around, the COVID, it has what we call incubation period, or if I'm exposed to COVID today, I may not show symptoms till like 5, 6, 7 days. But just before I become symptomatic, I can transmit it. So that's the huge difference, is that a nursing home person who's confined to their bed probably is not spreading it a lot to a lot of people. But somebody who's active, I may be kind of like infectious, go to post office, go to the bakery, go to my kid's school, or see patients in my office and spread to like multiple people. And that's what exactly is happening, is that Delta variant is number one, more virulent. That means that intrinsically it spreads to more people. Number two is that since it is affecting the younger people, the scatter is even more. Other difference which I feel is that people are getting sicker and they are relatively younger, and we have seen marked differences in our ability to get them off the ventilator if unfortunately they become sick and get onto the ventilator.
Well, Dr. Bambra, I want to thank you so much for a very informative interview, and thank you so much for being on with us tonight. This entire interview, as well as much more COVID-19 information, is available on WSILTV.com. We'll be right back after this break.